How are you?
Good. How are
Finally,
you?
Mohit. It's like 5 years that I wanted to
It's been
have
too long.
you.
Thank
The
you for inviting
happiest
me.
woman in the world.
Thank you.
Okay. It's a pleasure to have you. You are, an icon of testosterone and all that is around. You know how fascinating is that topic to me? It's just kind of, I used to be a little obsessed that all you can do with testosterone and the meaning of this hormone that we sometimes overlook, overuse, underuse. So give us your take on this, and we can wait to hear you.
Thank you so much. If they can play my slides, that'd be great. Thank you so much. Can you see my slides? Can you hear
Hello?
me?
Yes, we
Yes.
can see it. Yeah.
Two choices. I had sent in a recorded version. Would you like me to just do it this way? Is that easier?
We can see your slide. You can go ahead.
Okay,
It's
great. Let me
okay.
go
Yeah.
ahead and begin then. Thank
Yeah.
you so much. Okay, well, first
Okay.
of all, thank you very much for this kind invitation to present at this meeting. And I wanted to thank Dr. Ingrid Persky for this invitation as well. And today I'll be discussing testosterone, but really diagnosis, treatment, and long-term health implications. So these are my disclosures. I do consult for companies that make testosterone products. And in addition, I was on the steering committee for the Traverse trial, which I'll be discussing today. So I'd like to start by talking a little bit about age-based screening recommendations. I went through and looked at all of the age-based screening recommendations in the United States when a man's in his 40s, when he's in his 50s, his 60s, and 70s. And you can see that we do lipids and we do blood pressure and we do other things as well. But nowhere do I see the word testosterone. Testosterone is not used to screen men for average screening in the United States. But what if we had a single blood test in men that could predict cardiovascular disease, depression, osteoporosis, diabetes, obesity, prostate cancer, anemia, and male infertility? What if we had that one blood test that could predict all of these conditions? Well, we have that blood test. It's actually testosterone. In fact, testosterone is one of the best barometers of a man's overall health. Did you know that men with low testosterone are much more likely to have cardiovascular disease, depression, osteoporosis, diabetes, obesity, prostate cancer, anemia, and male infertility? Let's look at some of these statistics. Men with low testosterone levels are 17% more likely to have cardiovascular disease. They're 50% more likely to have a bone fracture, 52% more likely to have diabetes, 69% more likely to have obesity, 86% more likely to suffer from depression, 6 times more likely to have male infertility, and almost 2 times likely to have increased mortality. So how do you diagnose low testosterone? It's very simple. You just need to have a blood test, and the blood test we use in the United States is 300 nanogram per deciliter, and you have to have signs and symptoms. So what are some of those signs and symptoms? Well, increased body fat, reduced muscle mass, low bone mineral density. What are some of the symptoms that these patients complain of? They say, look, doctor, I have decreased energy. Another very common one is decreased libido, erectile dysfunction, diminished work performance, poor concentration and memory, sleep disturbances, and also depression. Now, testosterone was first synthesized in 1935, and it was an oral testosterone. But the problem with the oral testosterone is that it was actually degraded by the liver. And so when it was degraded by the liver, it used to cause hepatotoxicity. But in the 70s, they made oral testosterone undecanoate. This bypassed bypassed the liver and went into the lymphatic system. So no hepatotoxicity. And this had to be taken with a fatty meal. Now, this is a schematic looking at taking the testosterone, bypassing lymphatics, going into the bloodstream, avoiding the liver. Then in the United States, we did not get testosterone and decanoate until 2019. So there were almost 50 years where the world had the oral testosterone and decanoate, but we did not. But we got 3 oral testosterone decanoates in the US. They're called Talando, Kysotrex, and Jatenzo, and they have to be taken only twice a day with a fatty meal. And I would say that these medications actually work quite well. This is looking at the pharmacokinetics. You can see that these medications should be taken at breakfast and dinner, but I prefer to give it at breakfast and lunch so that you can put the second curve on top of the first curve and you get most of the medication during the day, mimicking diurnal variation. Now, I have to talk about this concept that testosterone may cause a heart attack. Molly Shores in 2006 was the first to show that men with low testosterone levels were much more likely to have increased mortality. Numerous studies after that study showed that men with low testosterone levels were more likely to have increased mortality and increased risk for heart attack. But the AUA guidelines even put in their guidelines, men with low testosterone levels should be informed that there's increased risk for cardiovascular disease in men with low T. But they also said that if we give a man T, we're not sure if that it will actually increase the risk. Now remember that these guidelines were published in 2018 before the Traverse trial. And the Traverse trial came out in 2023, which showed that there was no increased risk in cardiovascular events. And that's what I need to share with you today. In 2015, there was some concern that testosterone may increase the risk of heart attack. And the United States, they changed the label. The FDA put inside the label that testosterone is inconclusive whether it increases the risk for heart attack, and patients should be counseled that testosterone may increase the risk for heart attack. Well, the Europeans looked at the same data and they said, no, we're not going to change our warning, but the US did. And in 2015, the US, the FDA gave guidance and asked the industry to run a large clinical trial. This trial was called the Traverse trial. And the main goal of the Traverse trial was to see if testosterone increased the risk of a heart attack. This is the largest randomized placebo-controlled trial ever published in men between the ages of 40 and 80. In order to be in this trial, you had to have increased cardiovascular risk factors, or you had to have cardiovascular disease. Men had to have low testosterone. We had 5,246 patients, and the mean duration of treatment was 22 months. Mean follow-up was 33 months. Now, this is showing you the one-to-one that we had, testosterone gel or placebo, and we had data all the way out to 48 months. I'll just summarize the endpoints. The primary endpoint is really any non-fatal MI, non-fatal stroke, or death due to cardiovascular causes. Secondary endpoints were any procedure on the heart, like a CABG. Tertiary procedures were any DVT or PE. We also had some prostate safety. We looked at any prostate cancer, any high-grade prostate cancer, and we looked at BPH and LUTS. All 5,246 patients got the IPSS questionnaire to look at BPH and LUTS. This is the most important slide. Basically, there was no difference in non-fatal MI, non-fatal stroke in those men receiving testosterone versus placebo. It was the same. Now, finally, in February of 2025, which is approximately a year ago, the FDA put out a statement saying that they will now change the label again and take off the warning that testosterone causes cardiovascular risk. So that's a big win for us. And so essentially, because of the results of the Traverse trial, they are going to remove the warning. I just want to summarize a couple other things from the Traverse trial. The Traverse trial showed that there was no increased risk in BPH. And the Traverse trial also showed there was no increased risk in prostate cancer, which is very important. We also know that testosterone is extremely important for sexual function. We know that men with low testosterone levels are much more likely to have sexual dysfunction, more likely to have ED due to problems with cavernosal nerves, cavernosal smooth muscle, and the endothelium as well. There's also studies to show that men with low testosterone levels are much more likely to have Peyronie's disease. This is looking at 6 studies. 5 studies supported that men with low T have increased risk for Peyronie's disease, and that lower testosterone levels were much more likely to be associated with greater penile curvature and penile plaque. What about depression? We know with men with depression, as you see, as the testosterone level goes up, the depression symptoms continue to go down. Strong correlation between depression and testosterone levels. And there are numerous studies showing the same thing. Men with lower testosterone levels are much more likely to suffer from depression, and many studies show that by giving testosterone, you can actually improve depressive symptoms in men. What about diabetes, obesity, metabolic syndrome? There's a strong bidirectional relationship between diabetes, obesity, and metabolic syndrome. And it's not surprising that they share many of the same risk factors. This is a study by Corona looking at men. If you look at the relative risk of hypogonadism, as you increase the number of components of metabolic syndrome, you increase the risk of diabetes, hypogonadism, up to tenfold if you have 4 to 5 components. Looking at it another way, men with greater numbers of metabolic syndrome components, you see that you see a significant decline in serum testosterone levels. And this is very important. This is looking at obesity. What effect does obesity have on testosterone? If a man loses 10% of his body weight, he will actually gain 85 nanogram per deciliter in serum testosterone. If he loses 15% of his body weight, he can gain almost 250 nanogram per deciliter in serum testosterone. So we know that weight loss has a profound effect on increasing serum testosterone. And now with the advent of the GLP-1s, we see a significant improvement in many of these patients' serum testosterone levels. And looking at diabetes, this is probably one of the biggest studies called the T4DM study, came out of Australia. Over 1,000 men receiving testosterone and lifestyle intervention or placebo and lifestyle intervention. And they were looking at which men would not progress to type 2 diabetes. So in men with prediabetes, 50% of the men would progress to diabetes if you took testosterone. The difference was 7.6% in the testosterone arm, 14.9% in the placebo arm. But what was very interesting is that men with newly diagnosed type 2 diabetes, after 2 years, there was a 13% reduction in type 2 diabetes in men who took testosterone over placebo. That is significant. Now, what about prostate cancer? We were taught that men with higher testosterone more likely to get prostate cancer, but the literature suggests the opposite. Numerous studies show that men with low testosterone levels are much more likely to have increased grade, Gleason score, positive surgical margins, higher incidence of seminal vesicle invasion. And so we know that it is low testosterone, not higher testosterone levels, that are associated with prostate cancer. And I want to be careful in saying associated, not causing, but associated with prostate cancer. What about osteoporosis? We know that hypogonadism accounts for up to 30% of men having osteoporosis. In fact, if you look at the hypogonadal men, they're 2 times more likely to have a bone fracture. And finally, what about fertility? So this is a study looking at 900 couples with unexplained infertility, and 781 men had a median testosterone level in the normal range. But if men had a testosterone level less than 264 nanogram per deciliter, not only did it increase the risk of having abnormal morphology, but the odds ratio of live birth decreased by 40% in couples if the partner had a low serum testosterone level. So let's look back at that first page that I showed you about screening. I cannot think of another blood test that's a better indicator of a man's current health and his future health than testosterone. But if you look at all the recommendations for screening, testosterone is not listed as a hormone that should be tested on annual screening, which I think is wrong. I think that every man over the age of 40 should have an annual testosterone screening because it is the best window in his overall health. So in conclusion, low testosterone can negatively impact a man's mental, physical, and sexual health. Low testosterone is associated with cardiovascular disease, osteoporosis, diabetes, obesity, prostate cancer, and depression. And men over the age of 40 years should be screened for low testosterone. And testosterone appears to be the best barometer of a man's overall health. Thank you so much for your attention.